Ready.
Good morning, all. This is Debbie Melnyk, joined by my colleagues Sherry White, Jana Eller, and Ivan Burkle. This is session 7 of 8 classes focused on the milestones for the Transforming Clinical Practice Initiative. Today's class is focused on person and family-centered care-related milestones. You see there are several. The 4 in specialty care, 4, 5, 12, and 17, are also in primary care, and there are 2 additional ones in primary care. So let's get started. By way of background again, you know there are 22 milestones for specialty practice, 27 for primary care, and scores on each milestone determine phase completion. Milestone classes are outlined here on slide 3, and we are in number 7. Recordings for all the previous ones are included in the weekly newsletter that Jana sends out and also available on VCSQI.org website. We have 1 class after this week, and that one will focus on business strategies. So today's objectives will review the scoring for person and family-centered care-related milestones. That's 4, 5, 12, and 17 for specialty practices, and 4, 5, 7, 15, 17, and 22 for primary care. We'll outline the strategies for meeting each of the milestones and review the relevance of the milestone scores to phases. And then if questions, we'll open it up to hear from you. So here again, you see the milestones for specialty and primary care that are focused on person and family-centered care. So let's get to it. We'll be referencing the change package throughout today's presentation. Shown on this slide, you see that the tab practice plan lists the work that you need to still continue to address based on your practice assessment scores. And then for each milestone where work is still necessary, you can scroll over to column H and click on the underlined number. It will take you to the change package and show the tactics you can use to help meet the milestone. So these are the change package strategies where they're located that you'll see on some of the subsequent slides. So milestone 4 for specialty care is also number 4 for primary care. And this milestone addresses the involvement of patients and families in goal setting, decision making, and self-management, otherwise known as shared decision making. A score of 3 is needed to complete phase 4. So you can be working towards this score and completing phases 1, 2, and 3 as you score a 1 or a 2 on this milestone. So what are the strategies for meeting milestone 4? Well, to involve the patient in goal setting and shared decision making, you need to understand what's important to the patient. And this is where the practice of motivational interviewing comes into play. Learning about the patient from the patient and family, what matters to them, what motivates them, and tying those personal goals and meaningful activities to the patient's healthcare and to the activities that they need to take on and address themselves in order to meet their own expectations for life, the things that are important to them. In a few slides, I'm going to show you where you can learn more about these approaches for motivational interviewing. But actually just completing a care plan with the patient or family is another strategy that helps you meet this milestone. You, as the caregivers, know what the plan of care needs to be to help the patient either maintain their current level of health or improve it. So sitting down together with the patient and creating this together allows the patient to have a voice, to ask questions, to agree, to perhaps say that activity won't work for me. Can we come up with something else? Using evidence-based decision aids. These are aids that will lay out for the patient activities that help meet the healthcare goals. Sharing test results along with education about those tests. Some of this gets to sound a little redundant. This next one is also developing a plan of care together, in this case using an electronic health record. Using evidence-based techniques such as teach-back. Teach-back is so simple to do, and one of the most effective ways for us as healthcare providers to determine if the patient understands what we've tried to teach them. This might be demonstration, perhaps of an injection the patient needs to give him or herself, or it could be simply restating what we've taught them. And this gives us an opportunity to confirm or not confirm that the patient truly understood what we were trying to teach them, and then an opportunity to try again and teach them again. So teach-back is a tremendous tool that is very simple to use right then on the fly as we're sharing information with the patient about their condition and about the strategies they need to include as they care for themselves. The list goes on for meeting milestone 4, providing a pre-visit development of a shared visit agenda with the patient. Most likely this would occur electronically or perhaps at the end of one visit, knowing that another visit is coming right up and determining what that agenda might be with the patient. Providing coaching between visits with follow-up on care plan and goals. This might be over the phone or again electronically. Providing peer-led support for self-management or even group visits. I myself participate in a group visit on an annual basis related to general women's health issues, and it's terrific. It's something that your clinicians might consider learning more about. You bring patients with the same condition or need into the same room and meet with them perhaps one at a time, but with their approval, of course. The conversation about their needs and how things are going is heard by other patients. And other patients learn from that and also can jump in. So it's initially sounds a little strange, perhaps, with talking about an individual's health in front of others. Of course, they have to approve and sign off that that's okay. But the benefits of a group visit really can be very positive for the participating patients. Providing condition-specific chronic disease self-management, support programs, training staff and self-management goal setting, standardizing action planning and plan follow-up process so the entire team can participate. And again, continuing to educate patients in a manner that they can understand and ensuring that they leave with a plan of care in hand. So here's a website with some more information. This is just a fact sheet about shared decision-making. The website is actually up at the top. It's a nice, short, kind of brief document that might help your staff understand shared decision-making a little more, and several other additional references here. I'm not going to go through and open them all, but the first is an article in the New England Journal of Medicine. The second highlights 3 best practices. The third is a much longer document. It's a toolkit related to shared decision-making from Dartmouth-Hitchcock. And the last is actually from AHRQ, the Agency for Healthcare Research and Quality. It's Strategy 6I as part of a larger document that AHRQ has. So I'd encourage you to look at these. One thing you might do is assign, depending on how many staff you have, is assign one link to each staff and have them come to a staff meeting and talk about the document. Might be a way to help zero in on which of these you might want to focus on with your staff in general. Motivational interviewing is a collaborative, goal-oriented style of communication with particular attention to the language of change. It's designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. This is a quoted definition by Miller and Melnyk. Again, here are some other references. The link here talks about the relationship between motivational interviewing and a long-known model for change, Prochaska's model for change. So again, I would encourage you to take a look at the information about motivational interviewing and have your staff and clinicians adopt what they can from this to truly understand what motivates the patient to change. Here's another guide. I've also pasted the table of contents here. It's a little fuzzy, but this is a great resource as well from the Community Care of North Carolina on motivational interviewing. Okay, Sherry or Ivan, anything you'd like to add here?
Thank you, Debbie. I would like to restate something that you mentioned, the importance of involving your staff. A lot of what Milestone 4 is asking of the practice is to make sure to engage your staff in the learning process with respect to patient engagement in their own care, things like that. When you think about the typical patient engagement in the practice setting, you know, an average of 40 minutes to an hour, the patient touches the patient service rep, the MA, the physician, the nurse, sometimes the lab person. So it really is important to engage all of your staff, or all of the staff that works with you, because at each of those touch points along the way, you have the opportunity to engage or re-engage the patient and involve them in their own care. So that becomes important. The other thing I wanted to mention briefly is that if you're practicing in the inpatient setting, a lot of times on the hospital intranet, you have access to tools such as the ones that Debbie mentioned, and TCPI, motivational interviewing as well. So that can be another resource to find tools for inpatient providers.
Thank you, Ivan. And I did go back to the scoring for this milestone. And again, you see, as Ivan suggested, a score of 1 means you really do have to train your staff and then develop approaches where the staff can use what they've learned to encourage and document patient involvement. The difference between a 2 and a 3 is how routine the process has become. Thank you, Ivan, for those additions. Okay, so now we're going to move on to milestone 5. And this milestone we've probably talked about before, especially if you've been on any of the previous PFE work group calls that we had. This milestone looks to whether or not the practice has a formal system for obtaining patient and family feedback, and they can document operational or strategic decisions made in response to this feedback. So this is also milestone number 5 for primary care, and a score of 3 is needed to complete phase 4. So what does this mean? Well, here are some strategies. Again, you don't need to do all of these things, but look at the strategies listed to consider which of these might work for your practice to serve as a vehicle for hearing from the patients and families, not about their own health per se, but about how the practice works. And are there things that can be changed to make the practice better meet the needs of patients and families that are cared for? So here you see, including the patient on an organization's board, many of your practices are small, perhaps solo practices, and you don't have a board. So this one might be out as a strategy. Implementing a patient and family advisory group. We'll talk a little bit more about that. It may be possible for your practice to do this. Regularly survey your patients and families. Many of you do this. The important point here, though, is are you looking at the survey results? And are you identifying common points of strength for your practice, as well as some that maybe are showing up by a few patients that aren't working as well as maybe they could be? And those would be ones to zero in on and hopefully make some adjustments and changes. That meets the second part of that score for milestone 3. Invite patients to your staff meeting. Include patients and families on any and all quality improvement initiatives you take. So for example, if on a survey you find that the wait time once the patient gets into the examining room is often noted as too long, so you might form a group, or you might hold a staff meeting that addresses this to come up with ways to address it. That would be a time to perhaps invite a patient to a staff meeting. That's the previous bullet and this one, to get that patient's input on what would make that wait either more tolerable, or where else might the patient see an opportunity to reduce the time. And here, this last bullet on this slide again is assuring that you are looking at patient experience regularly through whatever mechanism you are using to get that patient voice. So, patient and family advisory consoles, lots of resources now available on the internet. All you have to do really is Google patient and family advisory console, and many things come up. This one actually is from Plaintree, which has a reputation for really attending to patient and family engagement. And again, here's the table of contents so you can see a little bit more about what's included here. And these are additional resources. The first one is a link to a webinar we did last year with a national patient and family advisory console expert, and several others here. Steps Forward, forming a patient family advisory console, a toolkit from the Ohio Hospital Association, another one from the Burrell Institute, and one from HRET, which is part of the American Hospital Association. And even though some of these ring like they're for hospitals, the essence of what's important when you create a patient and family advisory console would be the same. Here's an example of the survey that Sherry helped us create for your practices, and this is also available for you to use if you want to survey your patients and do not have a survey at this time. This is set up on SurveyMonkey, I believe, but Sherry, maybe you'd like to comment about this for a minute? Get yourself off mute. Go ahead.
Thank you, Debbie. Yeah, so working with a few practices, there's not, I've noticed that, there's different types of surveys. You have patient satisfaction and patient engagement. So what we did here at VCSQI is we created a merged type of survey, and we offer it to our practices to utilize. We have, working with practices, we've decided to put it inside a tool, for example, SurveyMonkey, which is a free electronic survey tool that you can deploy various types of ways, and it's web-based. So this strategy also helped to focus on the manpower. If your practice doesn't have the manpower or a secretary or someone who can help analyze or compile the data and put it in a visual type of form, SurveyMonkey will be a good tool because it does that for you. So this is a good way for patients, again, to be more involved with the practice settings. A few of the practices that I have are fairly new. So as it relates to developing and structuring your department to be focused more so on the patient care and seeing the perspective of your patients, in addition to your staff, your other providers, this helps to create a synergy, if you will, as it relates to the perspective or the development opportunities within your practice, and you just make adjustments there. But yeah, these specific surveys touch on how involved the patients are with their direct care and have a good understanding of what information about their care is conveyed, and also the satisfaction with the environment. So this is a great tool, and we can help work with you to develop the tool or tweak it, if you will, to meet your practice needs.
Thank you, Sherry. And again, remember this, you don't just put the survey out, you analyze the results, whether you do it manually, because you could print this and hand it out to patients or mail it, or as Sherry said, SurveyMonkey itself will analyze it for you. And so to get that score of a 3, though, you have to show that you've done something with the results to address an area that perhaps needs some tweaking, some operational or clinical process in the practice that might need some tweaking to better meet patient expectations. There are even more strategies for meeting milestone 5, communicating to patients changes being implemented by the practice. That's kind of closing the loop to let the patients know that their input did make a difference, educating the patients on what they should expect and look for in a physician. And there are tools, again, that you may or may not want to give to your patients if you're afraid they're going to leave. But another benefit of looking at these tools that are available helps you kind of do some self-examination as to whether or not, you know, how a patient might answer the tools with your physician in mind, or you if you are the physician. Transparency in data, sorry, the bullet didn't show up there. This is showing to the patient various things about how the practice works. Running focus groups, including patients and families and staff feedback education events, using patient stories to start each meeting, and using real-time electronic systems such as the SurveyMonkey activity for capturing patient feedback. Okay, anything else anyone wants to add to this? Ivan, do you have anything to add?
No, well covered. Thank you, Deb.
Okay. Okay, moving on. Milestone number 12, which is number 17 for primary care. This milestone is looking at whether or not the patient can access a clinician after hours, with that clinician being able to access the patient's record. So this moves from a score of 1, where you have a live answering service, to a score of 2, where the practice uses a contract clinician or nurse triage service, so that, you know, the difference here is that the patient gets to speak to a clinician right away and not just get an answering service who then tries to get the clinician to talk to the patient. And then a 3 is the patient can speak directly to a clinician from the practice or on contract, who then also has access to the patient's medical record. So a variety of things here, a variety of ways. I think many of you at least have a live answering service. If you're connected with a hospital, you might have access to on-call staff, or if you are a practice with more than one clinician, you might do what is the way it always used to be done, was take call for each other and cover, you know, take turns covering on a 24/7 access. Probably the most well-known type of practice that always did this was an obstetrical practice, because someone had to be on call for that mother who went into labor at 2 a.m. So there are a variety of ways that you can continue to increase your score and continue to make access to one of your practice clinicians available to your patients. Making access to the patient, making access to one of your practice clinicians, probably the easier part of the criteria in a score of 3. The more difficult part might be that the clinician has access to the patient's medical record after hours. This will be difficult to achieve without an electronic medical record, unless that clinician is in the office and can access the hard copy of the medical record. So Again, there are two parts to that score of 3. Access to the clinician from your practice who has, this is the second part, access to the patient's medical record. Another way to help reach that is to expand hours in the evenings and weekends where there is access to the patient medical record then. To use alternatives to increase access to the care team and providers such as e-visits, providing same-day or next-day access to a consistent provider, providing a patient portal for patient-controlled access to health information, using warm handoffs for cross-coverage, and implementing a 24-hour nurse call line that is algorithm-driven, meaning here that depending on what the patient needs, the nurse may or may not be able to address that patient need or may need to contact the physician. Ivan or Sherry, is there anything you would like to add here? I think these are the last slides for this milestone.
All right, hi. The only thing that I would touch on a little bit more is how would someone who does not have an EMR can achieve a 3 in this regard? So in this specific milestone, a 3 would be given if this process would not be applicable. However, the goal is to be able to offer direct access to the provider after hours for urgent services or questions of an urgent nature to avoid emergency room visits, therefore decreasing increased hospitalizations. But I've noticed that a few of the practices that I have who does not have the EMR system, most of the physicians live close to the practice, so they would go home to pull files if necessary, but trying to put some other type of mechanism in place just to be more in tuned or engaged and be able to assess that recall as it relates to what is going on with that patient's condition. But I just wanted to point out that it may lead to the impression that this milestone would not be able to be achieved if you don't have an EMR. But if you don't have an EMR in this situation, it would not be in the capacity to implement this specific milestone. So therefore, it would be a 3, indicating not applicable for this specific milestone. However, the goal would be to include this in your practice in the future.
Okay. All right, thank you. Okay, this is the last of the 4 milestones that are exactly the same for specialty and primary care. It's number 17 for specialty and number 22 for primary care. A score of 3 is needed to complete phase 3. This milestone focuses on the practice offering multiple forms of alternative visit types. That could be email, Skype, or Zoom, as we're using today, or televisits, or communication media such as portal and texting, and that these have been integrated into the practice as alternative ways to communicate with the patient. So let's take a closer look at some of the strategies here. And again, remember, all of these milestones, I'm showing you many strategies from the change package. You don't have to do all of them. Picking 1 or 2, maybe 3, that help meet this milestone is all you need to do. Several are offered as alternative ways for you to meet this milestone. So using secure email visits, using telemedicine visits for patients in rural areas or for specialty consultations, using home telemonitoring options, instructions on receiving payment for e-visits and e-consults might be something, of course, you'll need to do with patients. I made reference earlier to group visits that I personally use. The last time I went to one of these, we were told about how we can access not necessarily the exact provider I was seeing, but one from her group, 24/7 for an e-visit or an e-consult. And she explained that in this instance, it is paid by me, not by insurance, $49. So giving that kind of instruction to your patient for any type of e-visit would be an important piece of information they would need to have. Using text prompts that say, go to the portal and look at messages that have been sent to you. Using a text appointment reminder with permission from the patient that you can use their phone number and text them that. Home INR monitoring, protocols for monitoring upper urinary tract infections or upper respiratory infections with a phone call. Additional ones continue on the next slide, using portal or texting to provide electronic reminders, using patient portals to avoid unnecessary visits to providers and answer questions by appropriate care team members. Using apps. Almost everyone has a cell phone, so apps can be used. Having portal messages go to the team, not just the provider. This can contribute to a faster response, perhaps, to the patient. Implementing a system for the ongoing review of workflow and train on updates. Assessing access in rural areas and consider alternative web access approaches, and using web-based video technology for homebound patients. Often I've heard, well, our patients are really elderly and they are not very computer savvy. Ask them about it. Some recent surveys indicate that patients in their 60s and 70s are more computer savvy than we think they might be. So don't assume that because you have an elderly patient population, they're not, using electronic devices. They may very well be. Ivan or Sherry, do you have anything you'd like to add to this?
No, Debbie, thank you. I think this was well covered.
Yeah, I would say, the essence, and I know we have so many small practices that that currently don't have electronic systems, portals, things like that in place. Again, the essence of what this milestone is getting at is giving the patient options and providing at least 2 or 3 ways for the patient to get in touch with the practice and for the practice to communicate with the patient. So don't get frustrated, if you will, by what you don't have in place. Just think in terms of, okay, if we had to provide 2 or 3 multiple ways to get in touch with the patient for them to get in touch with us, and work with your staff, engage them, engage your patients and ask them for their ideas. They will let you know what works best for them, and that'll make it easier for you to be clearer about what might work well in the practice overall.
Yeah, what we're using today, Zoom, is free video. Now, of course, you want to be clear that, what is happening over Zoom is protected with the patient. But thank you, Ivan. That's a great point. That don't concentrate on what you don't have, but look at some of these as potential ways of communicating with the patient as an alternative visit.
Yeah.
Okay, the next 2 milestones are just for primary care. That should be. Milestone 7 addresses whether or not the practice has implemented processes to promote continuity and as metrics to demonstrate that these processes are effective. A score of 3 here is needed, oh dear, I believe, to complete phase 4. So what are the strategies here? What does this measure mean? This is continuity of care addresses the patient's continuing connection with the same provider. So it could be the same team, the discussions we've had previously about panel assignments to know that the patient is seeing the same team, a panel of clinicians from your practice that are skilled in that patient's particular care needs, begins to address continuity of care. But here again are several strategies that will help you improve continuity of care, keeping the patient with the same clinician or care team. Now, if you have 1 clinician in your practice, this is pretty easy to accomplish. The measurement piece of this, as you saw a score of 3 says you need metrics to demonstrate that your processes for promoting continuity of care are working. The measures for continuity of care can look complicated. If you do a search on continuity of care metrics, there are some that definitely come up. They are looking at, those that are truly approved and tested read kind of too complicated. I decided to try to address in this short webinar today, but we can, I'd be happy to go over these if one of you would like to hear more about these continuity of care measures. We can do that one-on-one. But strict, as a solo office, if you've got one clinician, you're kind of done with measuring it because your patients continue to see your one clinician. Several strategies continue here on this next slide that you might want to take a look at. And again, remember, you don't have to do all of these things, but take a look at which ones perhaps you already have in place, which will help you say, yep, we've got a 3 on this. Ivan, Sherry, anything you'd like to add here?
Not for this one, Debbie, thank you.
Nothing here as well.
Okay. So the last milestone we're going to cover today is number 15 for primary care. A score of 3 is needed to complete phase 4. This milestone speaks to caring for the whole patient in that it is focused on providing behavioral health care support when necessary. So you see a score of 3 here is that the practice is able to consistently provide access to behavioral health providers, either within the practice or through a formal relationship. This is to assure that care is fully integrated or coordinated and respective provider roles are understood. We know that internal medicine practices are often where patients are diagnosed, for example, with depression and treated with depression. This is just one type of mental health issue that may be identified in a non-behavioral healthcare setting. Of course, we know there are many others, and this milestone speaks to a practice being able to identify patients who need behavioral health treatment or follow-up, and then consistently provides access to those experts. Several strategies here. Some will sound familiar to previous milestones we addressed that speak to knowing your medical neighborhood. Here you want to know you've got a formal referral relationship with mental health and perhaps substance abuse services in your community. Want to ensure that your primary care providers and other clinical staff have been trained at least in principles of behavioral health care and can handle routine needs. You want to include the use of non-clinical staff, perhaps, to provide screening and assessment tools, and to ensure that regular communication and coordinated workflows are happening between primary care and the behavioral health care providers your patients are seeing. You want to conduct regular case reviews for at-risk or unstable patients and for those who are not responding to treatment. A few more strategies on the next slide. Using the registry function if you have an EHR or a shared registry to support active care management and outreach to patients and treatments, to ensure that advanced directives are included in discussions with patient and family and are documented. You want to use web-based documentation support systems where available, and again, integrate behavioral health and medical care plans and facilitate integration. So these are all strategies that, again, are offered to you as ways to consider enhancing the behavioral health care referral or treatment you're even provided in your own office. Sherry, Ivan, anything you'd like to add here?
I would like to add two things, Debbie. One, this is an opportunity as well. If you think back to the quality requirements for MIPS participation, for primary care providers especially, you can consider including depression screening as one of the quality measures that you document and track and address with patients in your practice. The other thing I wanted to mention is that if you still have questions about where to go, what resources are out there. Right now, a lot of groups and agencies and providers that deal with behavioral health are getting funding from the government for lots of different programs to help them expand, to help them grow, to help improve their outreach in their local communities. And so now is a very opportune time to reach out and work with them as they are looking to improve the breadth and the quality of their services working with primary care practices. Just a thought.
Thank you, Ivan. Yeah, I'm glad you mentioned the depression screening as something that could be routine for your practice.
Absolutely.
All right, if there are any questions, we could take them now, or you can contact Ivan, Sherry, or myself. All right, well, that concludes our web class for this morning. I know we went a little longer than 30 minutes. There was a lot to cover today. So thank you all again. Have a great week.
Thank you.
Thank you. Good overview, Debbie. That was a lot.